So good morning and welcome to our convening on Medi-Cal Palliative Care, driving improvements in palliative care in Medi-Cal. I'm Judy Thomas, CEO of the Coalition for Compassionate Care of California. And today's convening is hosted by the Coalition and the California Healthcare Foundation. This convening is our opportunity to annually pause and take a look at where things stand with home-based palliative care and its availability to seriously ill Medi-Cal beneficiaries. Some of you may remember the days when we were able to hold these convenings in person, but today, rather than holding it as a single full-day event where we meet in person, we're holding it as two virtual half-day events. We do encourage you, when you go into the small groups, to have your video live so that we can see who you are. You will notice during the general portion that some of our speakers will have video on and some may have it off. But when you get into that small group, it's really helpful to have the video on. So it's going to be an exciting and interactive day today. When SB 1004 was signed into law in 2014, California became the first state in the nation to require that Medicaid beneficiaries have access to home-based palliative care. The first few years after the law was passed were spent figuring out exactly what Medi-Cal palliative care would look like and entail. Because again, we were trailblazing the way, not just for our state, but also for the nation. We've come a long way since SB 1004 was enacted, and now we have several years experience with standing up, operating, and delivering home-based palliative care to Medi-Cal beneficiaries, including how to do that in the midst of a pandemic. This convening is going to be rich with information. SB 1004, which enacted this law, this provision of Medi-Cal, shows what we can accomplish through the lever of policy, advocacy, and implementation. Our success with SB 1004 has bred other success. In January, the state released a master plan for aging, and a result of the coalition's advocacy with the palliative care community, the master plan incorporates the critical role of palliative care and advanced care planning in creating the future that we want for all of our older adults and those with disabilities, including Medi-Cal beneficiaries. Sometimes one law requires enactment of another law, what we call cleanup legislation. And that was the case with SB 1004. Because of the particularities of California's licensing laws governing hospices, the Coalition and the California Hospice and Palliative Care Association co-sponsored legislation to enable hospices to provide home-based palliative care without the fear of running afoul of licensing requirements. We continue to educate licensing and certification on the value of all providers, including hospices, to provide palliative care, and are co-sponsoring legislation to extend this authority. In addition, we're starting to see other states, including Hawaii and Arizona, following California's lead in developing home-based palliative care models and legislation. It looks like we have a slide that does have some of the housekeeping tips on it. So just a reminder, you probably have heard or seen all of these if you've read the email or you've been on a previous convening that we've hosted. So just please remember to mute yourself. We have you all unmuted so that when we go into the breakouts, you can chat. So please keep yourself muted until then. I'm going to introduce our objectives for today. Just as a reminder, which make sure you're in the right place, is we're going to look at both the progress and the challenges in delivering Medi-Cal palliative care as reported by health plans and providers, discuss the considerations, dependencies, and decision points with respect to the use of virtual or remote palliative care visits, learn about innovative practices used by palliative care providers serving Medi-Cal populations, and discuss plan and provider experiences delivering services that meet or exceed the all-plan letter requirements, and learn how those approaches impact volume, quality, and sustainability. So it's my pleasure to turn it over to our first speakers. Just a reminder that you got a complete set of the bios with the email about today's convening. Our first session is going to focus on Medi-Cal palliative care, looking back and looking forward. And we have two speakers, Dr. Ann Kinderman, who is an Associate Clinical Professor of Medicine at UCSF and the Director of Supportive and Palliative Care Services at Zuckerberg San Francisco General Hospital. She is a physician trained in both internal medicine as well as hospice and palliative care. And Kathleen Kerr is a healthcare consultant based in Northern California. Her work focuses on promoting the development, sustainability, and high-quality palliative care programs with a focus on rural and Medicaid populations. So Kathleen and Dr. Kinderman, I'm going to turn it over to you.
Great, thanks so much, Judy. All right, so the first part of this talk will be, the first part of our day today will be really going over what we know about what's going on with SB 1004 or palliative care for Medi-Cal patients based on survey information that we have. And Kathleen and I will both be presenting that information. So we've done this survey now 3 times at least. We did it 6 months into the implementation of SB 1004, and then we've done it yearly starting in the beginning of 2019. And so now we have 3 years worth of annual data to look at. And the reason we do these surveys is to really look at the growth and changes in Medi-Cal palliative care services since SB 1004 was implemented in January 2018. And in the surveys, we also want to look at the common challenges and the successful strategies to get services to either patients or members who need them, and share the important lessons that organizations are learning about how to do this better. We again surveyed both plans and providers who've been interested in this palliative care work for Medi-Cal patients. We sent that out last month, and we were very pleased to get responses from 19 plans out of 24 and 31 provider organizations. We had respondents from different regions across the state. Really, the whole state is represented. And whenever possible throughout these talks that we're going to be giving this morning, we're going to try to compare our results from 2020 to previous years. As we all know, 2020 was a year like none that probably any of us have experienced before. And so we wanted to look at how things may have changed based on the pandemic, but also really looking at just how is this benefit growing over time or changing. So thank you so much to all of the organizations that contributed information on the surveys. We know they are longer than maybe some of us would like, but they really gave us some very rich information. So thank you so much. To give you a little bit more of a roadmap as detailed in the agenda for today, I'm going to start off by talking about who our survey respondents were, the volume of patients and members that received services or were referred for services, and then some information about what we know about quality tracking. Just to make a note that please enter any questions or reflections or comments that you have in the chat as I go along. There may be a small amount of time at the end of my talk to start some Q&A. If not, there will be time for sure at the end of Kathleen's talk. We will have a 5-minute micro break, also opportunity to reflect on the information from this first part of the survey data. So we encourage you to take some time, take a breath, and think about what you've heard in this first part. Then we will come back, and Kathleen will be talking about the processes of care and how care is delivered and what we know about sustainability of these services. And then we'll hope to have about 10 minutes for question and answers from what we didn't get from Part A and Part B at the end. And then a break, I promise. All right, so let's dig in. We did get some demographic information about both the plans and the providers who completed the survey. So for our plan respondents, so again, there are about 19 plans that gave us any part of the information on the survey. Our plans are really of varying sizes, ranging from a small number of members of 20,000 to 1.3 million adult members. And as you can see, there's a really nice distribution, pretty even between mostly the medium-sized plans between 100,000 and 500,000 members, and then the remainder were either smaller or larger than that. And what we looked at is for the plans, how many palliative care organizations, providers, vendors, or sort of different ways that they're called, how many of those partners do they have? Well, there's one plan that said one partner, and there's another plan that responded 16. The majority have 4 or more partners. But when we dug in a little bit deeper and said, how many palliative care partners that you have were actually delivering services in the last quarter of 2020, and that number was actually smaller, not surprisingly. So most plans report having 4 or fewer palliative care partners who are actively delivering services as of a few months ago. For the providers who responded to our survey, most of them are independent, freestanding organizations, with 16% affiliated with health systems. It was about half and half, with slightly more than half having a not-for-profit status. Most of our palliative care providers who responded to the survey also deliver services to patients with other types of insurance, not surprisingly. So nearly all of our respondents also deliver palliative care services to commercially insured patients. Most, it was really nice to see, deliver services to dual eligible Medicare and Medi-Cal patients. The majority deliver services to Medicare Advantage patients. And I was personally really pleased to see that over half of our provider respondents reported that they also deliver services to fee-for-service Medi-Cal and Medicare also. We know that while what was rolled out in 2018 was a mandate for Medi-Cal plans that they needed to deliver palliative care services to their members, and then expanded to include fee-for-service Medi-Cal also as eligible for these services. But our question was really what proportion or how many of those fee-for-service Medi-Cal patients would actually get services? Well, we can't know the answer to that question, but it is really encouraging to know that a lot of the organizations that are delivering palliative care to Medi-Cal patients in managed care plans are also delivering fee-for-service Medi-Cal. And I was personally really pleased to see that over a third of the organizations that responded are also covering uninsured patients. So I think it really speaks to the mission of these organizations that are taking care of vulnerable patients. Most of our provider respondents also had other business lines. The majority, not surprisingly, since these are mostly home-based services, also have hospice services. About a third have home health services, and then a smaller fraction that do other programs like transition support from hospital to home, having focused advanced care planning or other educational programs for their patients, and then a small number that do home-based primary care and private duty nursing. Some of the other features that providers listed were taking care of children, doing primary care specifically in skilled nursing facilities, and having a freestanding physical hospice facility. And I really liked this comment. We provided opportunities for just open comments in our survey, and one of our provider organizations commented that offering palliative care has helped their agency to grow as a whole. It benefits that we can also directly bring on our home health team or hospice. So I really like this because it demonstrates this spectrum of services that can benefit each different type of service that this organization provides. Most of our provider organizations are pretty experienced in delivering palliative care. 90% have 3 or more years of experience. And in the still growing field of palliative care, 3 or more years of experience is definitely experienced. Most of the providers that responded to the survey provide services in multiple counties. And looking at the counties, because we asked specifically what counties are served, 53 of California's counties were explicitly covered, and 2 providers stated that they serve either large regions of the state, like Northern or Southern California, or the entire state. And half of our providers have 2 or fewer Medi-Cal partners, though it ranges from we don't have any partners or contracts yet to 10 or more. So majority working with 1 or 2 plans, but quite a range there. We wanted to know where care is actually provided. And not surprisingly, again, since these are majority organizations that have hospices as well, they are specializing in home-based care. Services also delivered, as has been mentioned, 90% also take care of patients in their home-like environment, so their skilled nursing facility or a residential care facility. I was really pleased to see that many of these organizations are willing and able to see patients in facilities like medical respite or in homeless shelters, since we know that a lot of our Medi-Cal palliative care members have housing insecurity. And so, but it's not easy to deliver care in those settings. So it was really encouraging to see that so many of our respondents are actively doing this. And then a smaller number that actually go into the hospital as well, delivering care and following their patients across settings. And the smallest number are seeing patients also in offices or clinics. We also are interested in what these teams look like. Who is actually doing the clinical service delivery? So about a quarter have other miscellaneous services represented, like medical assistants and other allied healthcare professionals. It was interesting to me that compared to other years when we've asked, where survey respondents said that they included grief counselors and care coordinators, other disciplines that supported the team, there were fewer people who reported those. And I wonder whether it's just become second nature for these organizations that do have a breadth of services like hospice and home health. They just don't even think about pulling those services in anymore because it's become so second nature. A small number have a pharmacist on their team. That stayed pretty stable from 2018 to 2020. Chaplain services, I am so pleased to see that even though chaplain services are not required under the SB 1004 mandate, that the majority of organizations that are reporting to us continue to say that they have spiritual care and chaplain services as part of their core team. And that stayed relatively stable in this range, around 77%. Community health workers, a significant minority that in previous years was around 26 or 27%. This year is around 19%. In Medi-Cal, with all of the psychosocial challenges that patients face, it is critical to have those needs met. And so we have seen consistently year over year that social workers are core members of this team and the most common members to have on our Medi-Cal palliative care teams. In terms of licensed professional nurses or vocational nurses, that number has bounced around a little bit. It started off, last year was up to 63%. The first year that we looked, it was only 36. So it sort of has gone up and down over time, but around half and half in 2020. Nursing services, also very common, working alongside social workers. That number has stayed in that range of sort of above 90% since we've been doing this survey. Physician assistants, slightly more in 2020 than previous years. That was around 7 to 9% in the past. Advanced practice providers as NPs, about 65% this year, around that number in the past. And down a little bit this year, the physician services that are included on the team. Last year, that was 89%, but up from the beginning. So what we see is really some patterns over time of what these teams look like, particularly a nurse, social worker, physician, and chaplains being the most common. We wanted to know specifically in COVID whether staffing had changed, and if so, how that had changed. And this was a free text response. And one organization stated that they have an increase in their home health aides and nurse practitioners, so actually expanding the providers. And the physical care that's needed. And I wonder about that in COVID with caregiver support, that maybe home health aides are needed even more with not having as consistent support from family or from hired professionals. There was higher than normal nursing turnover reported by one organization, and just interesting to think about why that might be in the pandemic of people who need to make different choices for their family or their own safety. One organization stated that they added virtual visits from physicians, and I would love to know whether that's phone, whether that's video. We'll talk about that more later this morning in terms of what that's looking like across different safety net institutions. Another organization, or a few, reported some staffing shortages, and most reported that this was really temporary during the peak times of COVID. But one organization did state that this is actually part of their feasibility concerns of, can we hire enough trained professionals to deliver these services? Not really necessarily leading to a staffing change, but one organization stated that they did more answering service. So one wonders whether that's a shift in roles for their existing staff, or whether they increase staff to do that. And a number of organizations really spoke to the way that care was being delivered shifted, and particularly for social work and chaplain visits. And another kind of indicative quote is that due to COVID, some of our staff do not staff in homes for referral visits, and noted that our patients are lonelier due to the distance from family during COVID and are unable to have family visits. So I have seen, certainly in the hospital, that puts more strain on staff when there's loneliness and there's just not as much support from family and friends. So just thinking about who responded to our survey, the plans that responded are representative of different sizes and regions. Most have a small number of active provider partners, and of our providers, most are independent organizations, they're experienced in palliative care, and most are making room for very vulnerable patients. So I'm going to spend the rest of this time really talking about the monitoring for our program, what plans and provider organizations are actually tracking. So what's interesting to know is that important context, that referral and enrollment data was originally required by the state, but that ended at the end of 2019 or the beginning of 2020. So anything that is currently being tracked is really voluntary. So we wanted to know how many patients or members are being referred. Do we know that? How many actually enrolled? Are those volumes changing over time as this benefit continues? And to what extent are other quality measures being monitored? So we asked the provider organizations how many patients were referred in 2020. And what we see is that more providers compared to before have more than 50 patients referred. So it's pretty even distribution from the very small numbers of patients that they're taking care of to over 150 patients in a year. And that 5% number, there was one organization that reported 2,400 individuals had been referred to their services. So comparing that to last year's information in particular, what you can see is that there's really been growth in this higher number of patients being served. So if we look at this volume across the 3 years we've done the survey, in 2018, 40% of our provider organizations reported that they had 50 or more referrals. That went up to 42% last year, and this year it's up to 62%. So we do see growth in the volume of patients referred to the provider organizations over time. From the plan perspective, we also are encouraged to see growth here. And again, more of a distribution, and it's a larger proportion that are seeing that over 400 referral volume for their services. And we had 13 plans responding and representing over 5,000 members who'd been referred for palliative care services. Comparing that to last year, again, you can just kind of at a glance look and see that there's been growth in these higher volumes of patients referred and the absolute number. So this is really encouraging to see. And right now, over 78% of our plan respondents said that they had over 100 referrals. So we then asked just a subjective question: what's your sense from the plans and the providers around how the volume of referrals is changing? And as you can see, the majority of plans and providers said that there's either a moderate or significant increase in the volume of referrals, with a small number of provider organizations that noted a decrease in 2020. Some comments around this referral question around it's a struggle to bring awareness to the community providers and referring eligible members to the program. And another organization provider said, that increasing awareness and education to be provided to the medical groups, physicians, and clinics about what palliative care is to be initiated by the state to encourage palliative care services. So I think there's a sense that this is something that the organizations want to do, but also that they're hoping for ongoing help from the state to help with awareness of this program. So now let's talk about actual enrollment of services. So we asked the provider organizations how many patients actually enrolled in your services. So we see that the largest proportion are in that 26 to 50 range, but as you can really see, there's quite a tail on this curve of organizations that are surveying over 100 patients. And when we look at that compared to previous years, the blue bars are the first year of implementation, 2018, the orange bars are the second year, 2019, and then 2020. You can really see quickly that from the provider organization perspective, in 2018 was really in startup mode, and most organizations had a very small number of patients that were served. And that has really grown into the sort of medium range of somewhere between 50 to 300 patients. And again, most providers reported a modest to significant increase in their patients served last year. We also asked this of the plans about how many members received services. And we saw, again, sort of a spreading of the previous curve. So most of the plan respondents are sort of in this range from 51 to 300 members who were enrolled. And when we look at this compared to previous years, a similar story to what we saw from the palliative care providers, in that it was really in the first 2 years, sort of this bimodal distribution of a peak in the sort of 1 to 50 patients, and then a later peak in the 300 to 400 range. And now it's really more evened out across this middle range of 150 to 300, 400 patients. We were really curious about this idea of what proportion of members referred actually get services, and we asked both plans and provider organizations to comment on that. And what we see is that there is a majority of our respondents this year of the plans said that they have 50% or fewer of their members actually who were referred actually enrolled in services. There is a significant minority, 45%, that said almost everyone who gets referred gets services. But I think it's an interesting question to ask compared to last year. Why is there a greater number of plans that perceive that it's harder to get from referral to enrollment? What might that be? Is there anything that's pandemic related? Is it staffing related? Is there a loss of buy-in from referring providers who might have endorsed the services previously? We don't know. And to that point, when we asked for comments, a plan said that this benefit offers a great options for many of our members, and it would be wonderful if members were more receptive or open to take part in the program. And another plan that said that more analysis should be done to look at why there's low utilization of these services that their members are eligible for. So heartily agree. It would be great to have some of the organizations who actually approach these patients who are referred think about or ask people why they aren't choosing to accept services. And a provider organization said, we really need more consistent referral and growth to continue the program that they're operating today. They started this in good faith and just really need to see consistency in their referrals. So some reflections here on referral and enrollment. Growth is happening, which is so encouraging to see, both for the majority of plans and provider organizations, both in terms of referrals and in terms of actual enrollment. And most of our plan respondents had about between 500 and 300 members that actually got services, palliative care services in 2020. More plans compared to previous surveys are reporting difficulty converting their referred members to enrolled members, and we really are not sure why, but that would be a really interesting thing to discuss. And certainly if you have thoughts on that, feel free to put them in the chat and we can talk about that maybe in the Q&A. So in the last section here, wanted to look at not just the volume of patients and members who were referred or who were enrolled, but what are organizations tracking still? Now that tracking is not mandated by the state, you don't have to report that. And we wanted to know, really in terms of thinking not just about tracking, but what are programs focusing on in terms of improvements? So we asked specifically because for those who don't know, there are accreditation bodies that actually provide certification in palliative care. And of our provider organizations, the majority, 71%, said that they're already certified by either the Joint Commission or a community health accreditation partners. And on top of that, there were another 13% of provider organizations that said that they've already applied for certification, but it just hasn't come through yet, or they haven't been evaluated, or they are planning to apply for this in 2021. So that's incredible, really, that so many of these organizations are not just internally thinking about quality, but really meet these standards. And one reason for that may be that over half of our plan respondents said they require this type of certification. So there's motivation from multiple directions here. Beyond this formal certification, almost 9 in 10 of the provider organizations said that they have formal quality assessment programs for their palliative care program. So that's required for hospices, not necessarily required for palliative care services, but this is part of the ethos of these organizations, that they really look at quality and want to try to make things better over time. Just terrific. We wanted to know specifically around what providers are monitoring for quality. And we asked about 10 metrics that are listed here. And over half of the organizations that responded to our survey said that they're tracking 9 and 10 of them. Most common measures that people reported tracking were some metric that really reflected assessing, managing, or impacting physical symptoms. So gauging pain or documenting that pain was managed or that it got better as a result of the intervention. Organizations are also interested in tracking advanced care planning services, both in formal documentation through advanced directive or PULSE forms, but also just that this conversation was started. I think that that's really nice to see that 80% of organizations are tracking that process of engaging their patients on advanced care planning, because we know that there are significant barriers to completing formal documents, particularly in the Medi-Cal population. The vast majority are tracking patient and or family satisfaction to know that people appreciate these services. That's a lot of effort to do, to collect that information. And so it's incredible to see that so many are looking at that. A majority are looking at the assessing, managing, or impacting emotional symptoms. Looking at this number, this conversion number of the percent of people who were referred who then actually received services. So 2/3 of organizations say they're looking at that. And I would be really curious to know what they're doing with that information and what things are coming up, kind of to the question I was raising before. A number look at this difference between the time between when there was a referral and when they started services. Through the pandemic, it would be really interesting to look at how those numbers changed. So I hope that organizations are looking at that. Functional assessments, completing or how and when you complete a medication reconciliation, and spiritual assessments are the least common of the measures that we asked, but still almost half. And it was really encouraging to see that of all of our provider organizations, almost all of them are tracking one of these measures. So then from the plans, we wanted to know what they're receiving, because there's not an exact match between the providers who responded to our surveys and the plans that responded. So they are still getting information on discharge status for enrolled patients. That was required reporting to the state, but it's still happening, even though it's not required anymore. The timeliness or amount of services delivered, looking at how fast the organizations get out there to see patients, assessing physical symptoms, also quite common, psychosocial needs, spiritual needs, documenting goals or advanced care planning. Interesting that fewer plans saying that they're getting this, even though the providers, it's pretty common that they're looking at that. Interestingly, not as many of our plan respondents said that they were actually getting member satisfaction information from the palliative care organizations, even though it seems like a good number of them may be collecting this. And the majority are actually requesting this type of information from their vendors. We asked plans about not just what they're getting, but what they're doing internally. And so the analyses that plans are doing and planning to do in the next year are largely around fiscal outcomes and utilization outcomes. Certainly makes a lot of sense 2 years into this benefit to think about what is this costing us and what is this saving us? Does it change end of life, in particular utilization, since those are quite costly hospitalizations and ED visits usually? A smaller proportion that are looking at care experience, and not as many looking at clinical outcomes. And I wonder whether that's because they're actually already getting that information from their provider organization, so they don't have to do it themselves. When we asked about improving operations in the next year, or just improvements, the smallest numbers said that they were going to look at operational functions. Maybe that's because they've already been doing this for a while and they have fairly smooth processes. Interestingly, big difference here in the providers in orange who said that they're interested in engaging new partners versus the plans. Far fewer of them are looking for new palliative care partners. There's a large focus on behalf of providers also in improving the collaboration with their plan partners, and many who are also looking to educate referring providers. And I really like that there's a pretty close mix here between plans and providers that are looking to do this in the next year. So there may be some good opportunity for collaboration there. And interestingly, more plans are looking at this, wanting to increase the percentage of enrollment. So I wonder whether that's the numbers, the majority of those plan respondents that said less than 50% of the people who referred actually get services. So I love that there's interest in looking at this over the next year. And both plans and providers want to find more eligible people. Some reflections on this quality assessment is that most of our respondents continue to actively assess the quality and or impact of palliative care services. And the majority of providers have Joint Commission or other certification already. And nearly all have a formal quality monitoring program. As I mentioned, plans seem to be more focused on their internal analyses on fiscal and utilization outcomes over clinical ones. And there's a really good alignment on wanting to identify and enroll more patients in the coming year. So I think I see that the chat has been active, and hopefully we will be able to get to a lot of those questions in our Q&A. But we want to give just some time here for reflection. So take a few minutes to think about what surprised you in the information that I've presented already, and why does it surprise you? What of the information that you heard would you like to discuss further with your team? And if there are any other questions that you want to ask or issues that you want to discuss during the end of our second session Q&A, please put them in the chat, and we'd love to hear from you. So with that, I'll give 5 minutes.
Hi, everyone. Kathleen Kerr here. We've reached the end of our 5-minute reflection period. I see a ton of terrific questions and comments going into the chat, and we'll have some time to explore those questions and comments after I get through the second part of the presentation of survey results. This one will focus on structures and processes, so how care is delivered, as well as reflections on sustainability. So the outline, structures and processes is a little bit of a grab bag. We'll talk about the plan perspectives on eligibility criteria. We'll talk about referral sources, features of health plan programs, payment mechanisms that are being used to cover the cost of delivering this care, and also practices surrounding remote care. In the sustainability section, we'll go over some assessments that plans and providers have done, thinking about how sustainable their programs are, concerns that folks have about sustainability, some perspectives on obstacles to delivering the best care possible, some global comments, a few reflections that plans offered about what they intend to do to help to integrate palliative care into the new CalAIM programs, and also wish lists, what both plans and providers shared with us about what they wish they had to make this all go better. And then we'll have a good 15 minutes or so at the end to explore questions both about the excellent material that Anne presented and then the material that I'm about to offer. So to start with, the concept of expanding on eligibility criteria, clearly one of the things that will impact the number of folks who get enrolled in this service is what proportion of plan members are actually eligible to receive it. And we asked plans if they had done anything to expand eligibility criteria. And we presented 3 different ways that they could do that. One is by expanding the clinical eligibility for one or more of the 4 specified diseases for SB 1004 palliative care. So heart failure, cancer, COPD, and liver disease. And nobody indicated that they did just that. And the mechanism for that is really sort of taking some of those specifics around indicators of advanced disease and perhaps relaxing them or not requiring evidence of, say, a specific ejection fraction or a MELD score, et cetera. Another way that plans could expand eligibility criteria, and almost 24% did this and just that, was they included other diseases. They took folks with other conditions besides just those 4 that were specified. And then we saw that 53% did both. They both relaxed a little bit the clinical eligibility criteria for the specified 4 anchor diseases and added other diseases. And so what we saw is only 24% are using the minimum required eligibility criteria for the program, which is really heartening to me because there's clearly a whole bunch more folks than just those with cancer, COPD, heart failure, and liver disease who would benefit from home-based palliative supports. The next topic in this bit of a grab bag around structures and processes has to do with what the plans are telling us about where their referrals are coming from. And we asked them about 3 specific potential sources of referrals. And what I'm reporting here is the proportion of the health plans that responded to the survey that indicated all or many of their referrals were generated by each source. And more than half, 56% of the plans indicated that all or many of their referrals were coming from internal plan staff, so case managers, utilization managers, et cetera. So really quite reliant on their own information and their own staff to identify members who would potentially benefit and initiate the outreach process. 35% of plans indicated that all or many of their referrals were coming from lists generated by plans looking at their claims data, using risk scores or algorithms and so on. So just using data resources in addition to their human resources to identify members. And 35% of our respondents said many or all of their referrals came from that source. Only 25% of plans said that all or many of their referrals were coming from external sources, such as primary care providers, oncologists, et cetera, those folks that are also involved in delivering care to these seriously ill individuals who we hope would know about palliative care and refer patients who would benefit. As a follow-up to this, we asked the providers about their perceptions of the efficacy of referral promotion strategies, so the things that they're doing to try to promote referrals to the program. Which of these felt like they were very or modestly effective? And then also, as a counterpoint, how many of the palliative care providers that responded to the survey just aren't using any of these 4 potential strategies? So the first strategy, where 84% of the palliative care provider respondents thought this was very or at least modestly effective, was doing informal or ad hoc outreach and education to potential referral sources. So catching, interacting with anywhere from navigators to oncologists to hospital-based teams, ad hoc, on the fly, hey, let me tell you about palliative care. 77% of the providers said that they were doing formal educational sessions with potential referral sources, so scheduling a time, doing a talk, being included in a staff meeting, and 77% of the the palliative care providers said that that was a very or modestly effective. 3% of the responding palliative care providers didn't use this strategy at all. 73% of the responding palliative care providers thought it was very or modestly effective to have a dedicated staff member that just engages with referring providers and or potentially eligible patients. So this is sort of a correlate to the hospice liaison position. Most of the provider organizations felt like this was a very effective strategy. 20% don't use it at all. And then the last category of a referral promotion strategy is the one where the health plan generates lists of potentially eligible members and then gives that to the provider organization and says, hey, you contact them, see if they're interested in palliative care. And so these chase lists have been receiving mixed reviews ever since SB 1004 Palliative Care was launched. In this particular survey, not quite a third of the palliative care provider respondents said, yeah, this is a very effective strategy, or at least modestly effective. Almost a third don't use it at all, and the others thought it was minimally effective or not effective at all. So a lot of mixed reviews about chase lists, but overall, folks seem to emphasize sort of personal, high-touch ways of promoting referrals. Ad hoc education, formal education, a dedicated staff member who just is out there in the community looking to promote referrals. Moving on to payment issues, we asked the health plans, what are the mechanisms that you are using to pay for palliative care? How are you compensating the providers that are delivering these services to your members? And still, 3 years in, we see that not quite a third of the plans, 29%, use fee-for-service only. And that's what we hear from the palliative care provider organizations. That's a very tough mechanism for paying for the longitudinal, team-based, home-based care that is indicative of the services delivered through SB 1004 Palliative Care. About over 40% of the plans offer an assessment fee, so that's payment for an initial visit where there's an assessment done to see if this person would actually benefit from enrollment in the program. That's really important because then providers that do that aren't at risk for receiving no compensation if, in fact, the person who's assessed winds up not being eligible or declining services. Most plans are paying 65%, are using a per enrolled member per month case rate, which is the endorsed best practice for compensating providers for delivering this particular type of care. 18% of plans offer a fee-for-service add-on to a case rate payment for patients that just need, or members that just need extra support. They need more visits than would be expected from a provider, and in that case, they can bill on top of the case rate. I thought it was really interesting to see, and this is the first time we've seen it, that 12% of the plans have a fiscal penalty that is imposed on the provider organization if performance measures are not met. And I just think this is a sign of the maturity of the field and the maturity of the clinical network in California that's delivering palliative care to Medi-Cal enrollees. If you expect to get incentives payments, perhaps. If you do better than expected, then it makes sense that you also might receive a penalty if you don't do as well as expected. A small number of plans offer incentives related to use of healthcare services. So, for example, avoiding hospitalizations or ED visits, an incentive for collecting and submitting data, and an incentive for completing the advanced care planning documents. None of the plans have an incentive attached to member satisfaction survey responses. So X% would recommend to friends or family, or X% rated their care as very high. And I think that may have to do with perhaps just some uncertainty about what's the right tool to use. And I think also because the response rates to these surveys tend to be quite low. So given that big array of potential payment mechanisms that are used by the plans, we asked the providers a similar question, thinking of your contracts, the contracts that you have for delivering SB 1004 palliative care, which of these payment mechanisms are featured in at least one of those contracts? And 47% of the providers palliative care providers who responded to the survey have at least one contract where they're getting fee-for-service only. But 83% have at least one contract where they're getting a per enrolled member per month case rate. And that tells us that these provider organizations, you all, many of the folks who are on this call right now, you're living in two revenue worlds. And I can imagine that that can be kind of challenging to project revenues, to deploy a team, to figure out the best way to manage just two very different ways of being compensated for your services. And then about half of the providers are eligible through their contracts for collecting an assessment fee if they go out and determine if a member is going to be eligible or not. And then a small number have written into their contracts incentive payments related to use of healthcare services, collecting or submitting data, or completing the advanced care planning documents. We also included in the survey questions about the features of the planned palliative care programs. And we asked these questions because what we've seen over the years is that there seem to be structures and processes that are associated with relatively more success in enrolling members, engaging in members, engaging referring providers, and also just having sort of a smooth operation where the palliative care providers can interact with the plan in an effective way, collaborative sense of what we can do to improve care, and so on. The majority of plan respondents endorsed having nearly all of these items within their palliative care programs. The first one, where 94% of the plan respondents said that, yeah, we're still monitoring the number of referrals and enrollments. And I think that's reflected by the large number of folks who actually shared those data with us for this survey. And that's really the bare minimum. You got to know how many people are using the benefit if you have any hope at all of knowing if it's being utilized appropriately or if the care that's delivered is any good. The 89% said that the palliative care program has a specific administrative home within the organization. And we've seen that this is super important. It doesn't kind of live between case management and utilization management. No, it lives very solidly in one department or another. Somebody owns it, somebody cares about it. 89% said that they had a dedicated contact person that palliative care providers could interact with if they have administrative issues or the specific members have needs that the providers need to interact with the plans on. 83% said that they have a clinical champion for the palliative care program, be that a physician or a nurse or another clinical person. 83% said that at least once a year, they train their staff on palliative care and the features of the palliative care program to keep that knowledge fresh. 83% also said they do regular reporting to the leadership about the palliative care program. 78% said they have provider-facing materials that describe palliative care and the benefit. 77% said they have standing operational and interdisciplinary care team meetings with the palliative care providers. And this can become increasingly difficult as a plan, as the number of plan members who are enrolled in palliative care increases. But what we've heard is that it's a really important way of having collaborative practice between the palliative care provider and the health plan. Only 65% have of the plans that responded have the palliative care program description on the website separate and distinct from the description of the hospice benefit. We know that one of the things that reduces referrals as well as enrollments, patient acceptance, is a confusion where people think that palliative care and hospice are the same thing. And anything we can do to de-emphasize that confusion, to help people view palliative care as being distinct from hospice, is really important. And only 65% have a standardized process for assessing quality of care delivered by their palliative care providers. Next, on to use of remote care. We asked the providers in which settings, if and how, they use video visits in combination with in-person visits when delivering palliative care. And of course, this is a really important item a topic to think about in 2020 when COVID did so much to change the way that care was delivered. And what we heard from the provider organizations is that 87% of them in 2020 used video visits in combination with home visits. 19% used video visits in combination with clinic or office visits. Only 6% did not use video visits at all. So 94% of the providers, palliative care providers that responded to our survey, were using video visits in 2020. We then asked how they think this practice will, oh, somebody's sharing their screen. There we go, sorry about that. Careful with touching the screen share, folks. We then asked of the folks that, amongst palliative care providers, based on your experience of providing remote care by phone or video in 2020, how do you imagine your organization will use remote visits in the future? 58% said that they will likely sustain or grow the proportion of visits done remotely. They've been sold. 58% say this is the way to go. 26% said they'd likely continue, but probably at a lower volume than they do now, so reverting back to in-home visits a bit more, but not entirely. And 16% said that they would likely deliver all or nearly all care via in-person visits as soon as it's safe to do so. So it's not quite a 50-50 split, but still mixed perspectives on whether to do go all in and do more virtual care, remote care, or whether to revert back. And this split is also seen very clearly amongst the health plans. We asked them the same question. Based on your experience with remote care provided to your members in 2020, how do you imagine your plan will view remote visits for palliative care in the future? So when it's not just the only way to deliver care, but an option for delivering care. Well, 12% of the plan respondents said that they will likely ask their vendors to use remote visits as the main mechanism for delivering palliative care. Those plans are absolutely sold. That's the way to go. 41% of the plan respondents said they'll likely ask their vendors to revert to a model that uses mostly in-person care when it's safe to do so. And 47%, almost half, are not sure. They haven't yet figured out how they will use remote care for delivery of palliative care in the future. And that tells me there's a lot to talk about. And hopefully those discussions can be somewhat data-based in terms of figuring out, is there anything about remote care that is better or worse than in-person care, issues about accessibility and so on. And we're going to have a whole session about that coming up later this morning. So reflections on structures and processes. Most plans have expanded eligibility criteria. Most referrals are coming from internal plan staff, not for every single plan, but for the overall population of plans that responded to our survey. Providers focus on in-person outreach and education to promote referrals, and providers still have mixed feelings about chase lists. Some people endorse them, some people don't use them at all, some people just despise them and think that they're not at all effective. 29% of plans only offer fee-for-service payment for palliative care, and most providers are managing both fee-for-service and case rate revenue streams. 94% of providers use remote care, and 84% expect to keep doing so in the coming year. And 47% of plans are just not sure about how they intend to fold remote visits into their care models going forward. All righty. So that's it for structures and processes. Let's talk a little bit about sustainability and also just global impressions of experiences with delivering palliative care to Medi-Cal enrollees. The good news here, in terms of a direct question about sustainability, we asked both plans and providers, do you feel that your current model of providing or paying for SB 1004 palliative care services is sustainable for your organization? And the responses were nearly identical. About 2/3 of both plans and providers said, yeah, it's definitely sustainable for us. Nobody said it's definitely not sustainable, but about 1/3 in each group said, you know, it's too soon to tell. We cannot yet determine if this is going to be sustainable. Well, we asked plans specifically about any concerns that they might have about sustainability or efficacy of their program. And what I'm presenting to you here in this figure is the percent of plan respondents that flagged each of these issues as a moderate or major concern related to the sustainability or efficacy of their palliative care programs. And 57%, the biggest proportion, said that a moderate or major concern was the enrollment was too low. That felt like the biggest threat to them. Other issues, 36% thought that members are identified too late to receive a significant benefit. They saw that as a moderate or major concern. 29% felt that it was a concern that they had too few palliative care partners, or partners do not have capacity to meet the need. And I think as we see enrollments increase year over year, and in some regions where there's perhaps relatively less palliative care provider capacity than others, this might increasingly become an issue. We need more capacity to take care of the members who qualify for and want these services. 23% thought it was a moderate or major concern that there's turnover within the plan, and the folks who have been running the palliative care benefit went away. So you kind of have to fill that role from the bench, and that was a concern for 23% of the plans. 14% said it was a moderate or a major concern that the program costs outweigh cost savings. I thought that was a really promising statistic. That means that 86% don't think that's a concern. They're relatively certain about the business case for delivering these services, that I would imagine that they're at least cost neutral and perhaps doing even better. And really my favorite number on this entire chart is that only 7% of plans thought that the quality of care, quality of services that their members are receiving was a moderate or major concern. So most folks on the plan side feel that their members are getting good care, and that's terrific. I think that also tracks well with the information that Anne described about how many provider organizations have formal quality programs, and also how many are certified by the Joint Commission or CHAP. We asked providers about their concerns about sustainability or efficacy, so sort of the same type of question. We asked them about 4 topics, and here what we're presenting is the proportion of palliative care provider respondents that flagged each of these topics as either a moderate or significant issue. And for them too, and at an even higher proportion, they thought that too few patients being referred, too few patients being enrolled in their programs was by far the biggest threat to sustainability. 57% saw as an issue that compensation was inadequate to cover the scope of services that they're required to provide. I think we talked a little bit about how challenging it is to deliver home-based, team-based, longitudinal palliative care using a fee-for-service model. Well, it's also a bit challenging if the scope doesn't match the case rate that you're receiving. And 57% of providers, be it because of fee-for-service compensation or what they perceive to be too low case rate compensation, thought this was a threat to either sustainability or efficacy, delivering enough care to actually have the desired impact on the patient member. 23% of providers had thought it was a moderate or significant issue that they were having trouble retaining qualified staff, or finding qualified staff. And again, as these services grow, something that's been predicted for some time is that eventually we were going to hit a point where there's going to be significant workforce issues, where there's not going to be quite as many trained people as we need to staff the services that are in demand. And perhaps this 23% figure is the beginning glimmers of that issue in the home-based palliative care world. And finally, 3% flagged as a significant or moderate issue. Attention to palliative care is taken away from our core business, a very small proportion. And so what that tells me is that these organizations, most of which are independent community-based providers, see palliative care fitting in very nicely with their other lines of business. We asked providers about issues that are impacting the feasibility of continuing to deliver palliative care, so other issues that weren't in those 4 that we specifically asked them about. And these 3 quotes sort of capture the main theme. The first one is that the non-clinical tasks that plan partners are asking providers to do are really time-consuming and labor-intensive, and there's a worry that extra work that goes into going to meetings and logging data and doing education and all that sort of stuff is going to impact outcomes and financial sustainability. It's just taking too much time. The middle observation, fee-for-service reimbursement does not provide adequate payment, is something that we heard again and again, and multiple individuals reference that as an other type of threat to the sustainability of their palliative care service. And then the bottom one is just an often offered lament about the difficulty of changing the behavior of referring providers. You spend so much time educating these folks, but maybe you don't get any more referrals, or maybe you don't get any more enrollment, or maybe they don't really support palliative care, and that can feel frustrating. We also asked providers about their perceptions of barriers to delivering the best care possible. Again, the primary and specialty providers, who I think are the villains of the survey, were recommended as being a moderate or significant issue. These guys just don't introduce palliative care to their patients. Too few referrals, mentioned again. Competition with other planned programs that can create confusion and limit enrollment. And I think that this came up around health homes and whole person care and so on. Referrals come too late. Quite a few issues here that are endorsed by a minority of the provider respondents. And the ones that were least endorsed were patients having clinical needs that are beyond the scope of our service. Most felt very well equipped to take care of the clinical needs that their patients have. Lack of effective collaboration with plan partners was only endorsed by 16% of respondents. So most feel like they have really effective relationships. And finally, unable to meet patients' needs remotely during COVID-19. Most folks didn't feel that as a problem. Other barriers, a range of patient issues, referring provider issues, and plan issues, everything from patients don't like having palliative care come in if home health is there also, to resistance of primary care providers, referring providers getting confused and forgetting about palliative care because there's just so much going on. And finally, plan issues. Particularly, we heard this in a few places about how the contact information that the provider organizations get just isn't quite accurate, and that can create issues. In terms of the plan perspectives on palliative care and CalAIM, universal endorsement of the idea that these 2 programs, the enhanced care management, in lieu of services, other elements of CalAIM, we're going to integrate quite well with palliative care. Palliative care will become part of ECM for the high utilizing population. We will fully integrate palliative care as a part of our care model for CalAIM. I think it's going to be worth monitoring or discussing over time exactly how that manifests, and taking some steps to make sure that we're sharing best practices. In terms of general observations from the plans, it's a little bit of good news, bad news. We heard a lot from the plans, and there's 2 emblematic quotes here about just how palliative care is helping to really up the quality of care delivered to their seriously ill members. It's having an impact on avoiding non-beneficial utilization and so on. But there's a little bit of caution as well. One individual offered the observation that the reporting to the state was ended too soon, given low utilization. And also another provider, another plan, one that's using a fee-for-service payment model still says, we're trying to drive towards a case rate or shared risk payment model, but need more data to move from fee-for-service to more quality-driven payment structures. So this low enrollment really slows down the delivery of a lot of things. In terms of wish lists, Providers, they want more compelling data to convince the health plans to use value-based payment mechanisms. They want more access to information all around about their patients. They don't want to have to deal with as many IPAs and medical groups, which I understand can really complicate the delivery of palliative care. From the plans, there was a much more extensive wish list. They want additional data from their providers. They want additional funding to incentivize providers to promote palliative care, so similar to what's offered through Prop 56, using some tobacco funds to offer incentives for providers to do the right thing. Improved quality of member contact information. They want their providers to be able to take on more referrals, more public awareness. And I think, again, this gets around the issue of knowing what palliative care is, being willing to refer your patients, and then your patients actually accepting the services. So reflections on sustainability. Plans and providers report that their palliative care programs are sustainable, which is really good news. The low enrollment is the biggest threat to sustainability for both plans and providers. Providers are worried about the effort that's invested in non-clinical activities and if that's going to impact their sustainability or their efficacy. The plans fully expect to link palliative care and CalAIM programs. And if you look at the wish lists that were shared by both plans and providers, access to multiple types of accurate data was prevalent on both. So we have some data wishes that are common. And with that, that concludes the second part of the survey responses. So I think what I can do here is stop my share. Actually, I can leave this up and I can turn on my video so I don't have to worry anymore about straining my audio too much. Hi, everybody. And Ann and I would be pleased to take questions or to hear your comments and help to promote a discussion either through chat or you can unmute yourself and ask a question. And our colleagues, Kate, Monique, et cetera, I don't know if you have a chat question that you thought would be useful to throw in?
Sure. So hi, everyone. This is Kate Myers from the California Healthcare Foundation. We have a lot of questions that have come in through chat subsequent to Dr. Kinderman's presentation and during yours, Kathleen. So I've tried to organize some of them into some themes, and we may not get to all of them in the next 13 minutes, but we'll try to address at least the main themes that have come up. And feel free to continue to type questions into the chat. Even if we don't get to them now, they do help inform our thinking and planning about future educational sessions and activities. So a couple sets of reflections that came in after Dr. Kinderman's presentation were around what was described from the surveys about what's being monitored. So I'm going to just read a number of observations at once because there's some overlap and theme in the questions rather than going one by one. And then Kathleen and Ann, if you want to just respond to the whole of them, I think that might be the best way to run this. So in terms of what's being monitored, a few of the comments included one, that they found it interesting that some agencies are not reporting any quality indicators. So some provider agencies don't seem to be reporting quality indicators to their plans. Some were interested or surprised that the patient experience of care reporting was so low that that wasn't being reported back to plans, even when it looked like it was being collected sometimes. And there was one observation about, I think this was reflective of both the comments about what was being monitored and the comments that plans are intending to do fiscal and utilization analysis. There was a comment that it almost seemed a little inverse to this participant, that the focus on cost and utilization was there versus a focus on clinical outcomes and patient experience in terms of what was being routinely monitored. And the comment was that good clinical care and patient family experience of care would likely reduce utilization of high cost healthcare. So some of that, which things you emphasize. So I'll stop with those three comments and see if you have any reactions or responses to those.
Yeah, it's great. And I think, mostly what we can do is sort of speculate around, the why. We have the information, but we have, just ideas around what that is. And from my perspective, I think that the question that I put up around what are plans internally analyzing, and that was the one where sort of the fiscal outcomes and the utilization outcomes compared to the clinical outcomes. And that may be largely a function of what they have access to, right? So they know about ED visits and hospitalizations and how much they're paying for different services for their members, but it's harder for them to know clinical outcomes themselves, right? They have limited information into that. And so that's really a reflection of what they have probably access to, and may be more dependent. It's not necessarily they don't care about clinical outcomes or completely agree with the statement, which I do, of course, that good clinical outcomes should lead to better fiscal and utilization outcomes. So it's just more a matter of what the plans are doing internally in that question. And Kate, can you repeat the first one? The question was around, it's surprising that more providers are not collecting quality measures. And that question was specifically phrased around, are you collecting one of these 10 measures? So the ones that said we're not reporting any of these, which was, I believe, 3%. So it's very few. They may be following other things, but I will say that the things that we listed are really common quality measures. So I think that what that tells me is that almost all of the providers, at least the ones we surveyed, do really care about quality, and almost all are tracking something. And the last question, I think, was around the curiosity around, I think it's about 80% of the providers who responded to our survey said that they are asking for patient or family satisfaction, but only 22% of plans that said that they get that information from their provider partners. It is interesting because one would think, certainly if you have good things to report, you would report them to your plan. So I'm not sure what that's maybe there's a mismatch between the types of providers that responded to the survey and the plans that responded to the survey. It's a great question.
I just a small comment to add to that, and I don't want to take all our time talking about this, the topic of patient experience surveys. We recently did a review of this with a small group of plans and providers that are participating in a California Healthcare Foundation Coalition project. And what we saw was that there is no standard survey that's being used across providers. And even there's a couple plans that do gather these data themselves. They don't use a standardized tool that's in use in lots of other places either. So I think that sort of lack of consistent information can sometimes reduce the incentive to ask all of your providers to deliver it. Also, the very low response rates can make this something that perhaps the plans aren't focusing on. You can have providers that are relatively busy delivering palliative care, but they may have literally 0 returned satisfaction surveys in a quarter. And when the ends are so low, having that reported routinely can feel a little counterintuitive. And then also, I do want to mention that the question was, do the plans get these data from the providers? There's some plans that monitor member satisfaction with palliative care internally. And so that they wouldn't ask for it from the provider necessarily. They're doing their own check. But this is a really big, important topic, and something that I think is that the field and us in California need to tackle soon. Of what's the right way to gather this information, what's the right information to gather, and how do we use it?
Yeah, one other thing I was just going to add, Kathleen, to that is with respect to some plans collect satisfaction data themselves, and we didn't ask about that. Another comment that was made in the chat is one thing to consider is some health plans meet with their vendors quite regularly, monthly, for example, to review clinical outcomes of each member. So they have kind of different approaches to quality monitoring and clinical monitoring than perhaps the way we asked the question about reporting. Yeah. So some of the questions we're getting in chat are giving me all kinds of ideas for next surveys. People want even more information, so watch what you ask for, participants. Because you're the ones who respond to them. A couple other quick points before we take a 10-minute stretch break, which we'll do at 10:30. One, there were a couple points around interest in understanding more about how different organizations are approaching the issues of trying to increase engagement, increase conversion from referral to enrollment, to engage people earlier. So there were some questions about what do we know about whether referrals are coming earlier in the course of disease. We didn't ask about that or about length of stay or length of service for these palliative care programs. So we don't know the answers to that. But I'm just interested, Kathleen and Anne, if there's anything you'd want to offer kind of anecdotally or from your experience with other projects about strategies that you've seen being employed or tested to both increase referring provider engagement and to increase patient or member acceptance of palliative care services. Kathleen, I was thinking if there's anything you wanted to offer about some of the strategies we've been testing in Sacramento or any other concepts.
Sure. Very briefly, we have been doing a project in Sacramento that has brought together 3 plans, 3 palliative care providers, and then 3 organizations which we refer to as essential partners. So a navigation group that serves Medi-Cal enrollees, a big health system, and then a big medical group that only serves Medi-Cal enrollees. And what we've been doing with them is a series of relatively brief educational sessions with individuals who are deemed probable referring providers, high volume, high value, like inpatient palliative care teams or discharge planners at the health system and so on. And our early experience there is that this sort of focused outreach with information that's tailored to the role and background of the potential referrers, so something a little different for the docs versus the case managers versus the community health workers. Our early data showed that we were able to increase external enrollments and external referrals by 60%. And part of the thinking is that by working with these essential partners that already have a relationship with these patients, that there can be a transfer of trust, and then the probability of accepting services goes up. The early data is very promising. We'll see if it holds going forward. And I think what we learned there too is that some plans that have sophisticated systems of monitoring referrals, enrollments, and so on are able to track that gap between eligible and offered and declined and or not enrolled, and be able to pick up the reasons for that. And some of those reasons are modifiable. So if you have a bunch of patients just declining, well, you can find out why. Maybe you need to do different language when you present the program to the person. So that there's information to discover and some strategies to use to try to, in particular, increase external referrals and also increase member acceptance of services.
Thanks, Kathleen. So just maybe a couple points to raise before we close for our break for 10 minutes and move on to our next session, because these are actually a nice lead-in to the next session, which will focus on virtual care. There were a few questions, I think, trying to clarify a little bit about what was going on with virtual care over the past year and how that compared to the past. And I think Kathleen went over some of those data after those questions were entered. We didn't actually ask what portion of the televisits people were describing were video versus phone. So we don't have those data, but it's a good question. We certainly know broadly that you'll hear in just a few minutes that certainly across the board in safety net settings, more virtual care visits are being delivered by phone. We'll hear more about that in a moment. One point I thought was interesting, one of the commenters noted that 1/3 of the plans were concerned about having enough capacity for palliative care services. And so they were curious sort of how they were thinking about capacity with respect to virtual care and paying for virtual care. And knowing that the plans seemed uncertain by our survey about what their plans were for virtual care going forward. So one participant was making this connection between capacity and virtual care.
Yeah, that's
any
a solution.
Final comments? Yeah, Kathleen or Anne, any final words before we give everyone a 10-minute stretch break before we move on to our next session?
I'll just say, and I'll let Anne close this out, I'm so grateful to all of you. I'm guessing that most of the people, a lot of the people who are on the phone or on this video also completed the survey. Just want to thank you very much for that. I think in particular for digging up those bits of data that took some work, like the number referred and number enrolled. A lot of it was your impressions, but we only know what we know about how this program is going because you all took the trouble to complete those surveys. So very much appreciated. We promise to try to keep the length down for V4, if there is a V4, and really useful information. And I hope that you found it interesting.
Took the words out of my mouth. I think, we have really appreciated being able to be part of this work to try to share what's going on with you all so that you have a sense of what your peers, or whether those are other palliative care providers or other plans, what their experiences, so that we can share lessons learned and hopefully help you all improve. So look forward to the rest of the morning after our break.
Thank you. So with that, everyone, we are going to take just 10 minutes and we will start promptly at 10:40 because we have another great, exciting session that will include both presentation time and breakout group time to talk about virtual care. So we will see you in now, it looks like 9 minutes. See you at 10:40. Thanks, everyone.